Men with prostate cancer are often offered the chance to have active surveillance rather than treatment and see what happens with the cancer over time. A potentially disturbing study in this week's Medical Journal of Australia suggests that active surveillance isn't being done as well as it should, which may or may not have serious consequences. One of the authors is Associate Professor Declan Murphy, who's a urologist and Director of Genitourinary Oncology at the Peter MacCallum Cancer Centre in Melbourne. Declan, welcome to the Health Report.
My pleasure.
So what are the criteria for men to go into active surveillance?
Well, any man diagnosed with localised or early prostate cancer has three options. Option number one, they could choose not to be actively treated, and we call that category, broadly speaking, active surveillance. Number two, they could have surgery. Number three, they could have some form of radiotherapy. But I think what we have recognised in recent years is that there are particular cohorts of men diagnosed with early prostate cancer in whom surveillance is a very appropriate and safe strategy. A significant proportion of men nowadays diagnosed with early prostate cancer can safely be managed with active surveillance.
So this study that you did was to look at whether active surveillance was done according to the way it should be done, presumably for safety reasons and protecting the men against the cancer spreading without them realising it. So when it's done properly, how's it done?
There are some criteria by which we think men should be monitored if they are not to have a progression of their cancer and miss the opportunity to have curative treatment. And broadly speaking, the two main recommended tools we use are, number one, PSA testing, so simple blood test, and number two, a further prostate biopsy. So what we might typically see in the very many men that we keep on surveillance is either the PSA remains about the same level, it doesn't have to be exactly the same level, it can fluctuate up and down, or it will creep up a little bit as the years go by. But certainly if we see a pattern of PSA rising consistently, so it might start off around 5 and then it goes to 6.5 and 8 and 9, so continuous rising is one of the little red flags we would see in a man who's on surveillance. And if we saw consistent rising over a year or two of surveillance, it may be a call to do some further tests like another biopsy.
So you looked at whether or not men adhered to this. What did you find?
Yes, so this is a study that came out of the Prostate Cancer Outcomes Registry in Victoria. And this is a really very well-established registry of newly diagnosed men in Victoria that's been running for a number of years and has now been extended to a national study supported by the Movember Foundation. So we capture about 80% of all newly diagnosed men with prostate cancer in Victoria. So we do have a large database running back for almost 10 years now. So in this particular study, we wanted to look at men who had been diagnosed in Victoria over a 6 or 7 year period in whom active surveillance was the management strategy. And so just to give you some idea that first of all, surveillance has been very well accepted by the clinical community and indeed patients in Australia. About 60% of all men diagnosed with low-risk prostate cancer, early favourable prostate cancer, are managed on surveillance. So that in this study ended up at about 1,600 men whom we had full data on.
To what extent did they fall behind?
Yeah, well, we set a pretty low bar on this. We said that over the 2-year period following the initial diagnosis, a man should reasonably expect to have 3 PSA tests and 1 biopsy. And somewhat to our surprise, we found that the proportion of men who met this low bar of 3 blood tests and 1 biopsy over the following 2 years was only 25%. Only 25% of men actually had 3 blood tests and a biopsy, meaning that 75% of men actually didn't meet what we thought was a pretty low bar to be safely on surveillance.
Do you know why?
There were a few predictors in it that made it more likely that a patient was likely not to comply. The first was being an older age, being more than 66 years of age. Number 2, if they were managed in private practice, because we capture patients both in public and private, they were more likely to be compliant. It may well be, therefore, that they've had a single clinician looking after them, or perhaps their socioeconomic profile is a little bit different, but certainly private patients tended to be a bit more compliant than those patients in the public sector. And third, interestingly, The type of biopsy which diagnosed the patient also seemed to be predictive. And the old-fashioned biopsy that goes up through the back passage to diagnose men.
I'm clenching my buttocks as you speak.
I know you are. The old transrectal biopsy has, remained the mainstay of biopsy around the world.
But it's not particularly safe.
It's not particularly safe. In Australia and in practices like ours at Peter MacCallum Cancer Centre, we abandoned that very many years ago, and we only do biopsies through the skin, which is a much safer way of doing it. And we found in this study that if patients had one of those biopsies at the start, that was also predictive of them being less likely to have a further biopsy over the following 2 years.
So, sorry, if they had a transrectal or a transperineal?
Transperineal.
They didn't like the transperineal.
Well, yes, you might say, is that because this is a terrible biopsy? Well, no, as you've already mentioned, it's very safe. We do them under general anesthetic, so they're also quite comfortable. We believe, or we speculate, the reason why men are less likely to have a further biopsy is because transperineal biopsy through the skin is not only safer, but it's also more accurate. We have very high-level evidence from the UK now showing that...
So in other words, they may have had a negative biopsy and you think, well, I can relax for 2 or 3 years.
Totally right. So we have a lot more confidence that a transperineal biopsy is actually more representative than the old-fashioned truss biopsy. So we suspect this is clinicians sort of having more faith that the cancer which they think is suitable for surveillance is truly suitable for surveillance, and maybe these guys don't need a biopsy.
So you might actually, paradoxically, your low bar might be actually too high. These men don't sound as if many of them are getting into strife and turning up with cancer, even though prostate cancer is a slow-growing cancer and you're only going to find out after a while.
Yeah, I totally agree with you, Norman. And, I think in many aspects of medicine, as you know, we tend to be overcautious. We tend to overtreat patients. And I think it's the same here. I think just because 3/4 of these men didn't meet what we set was a quite low bar, it doesn't mean that 3/4 of these men are going to have a bad outcome. I think we are a little concerned that there needs to be more awareness about the fact that people do need to be monitored and making sure they're not lost to follow-up in the public system, for example. But I do think that if men are now being diagnosed with good biopsies and MRI scanning, which is a whole other factor that we couldn't measure properly in this study, it may well be that they are still doing very well indeed. Correct.
And just finally, with the MRI scans, $450, $500 out of pocket without a reimbursement, is reimbursement on the card so that men can actually have an MRI rather than all this other stuff?
Well, actually it is, and that was actually terrific news in the recent budget, which flew under the radar.
So they've already announced it, have they? Well,
they have. Yeah. From the 1st of July, men in Australia who either are coming up to a first biopsy because there's a suspicion of prostate cancer will be allowed to have an MRI without
Okay, put your hands on your heart now, Professor Murphy. How many radiologists in Melbourne know how to read an MRI of the prostate? Now tell me the truth.
I'm very friendly with at least 50 radiologists in Melbourne who are very good at reading MRI scans. But look, all kidding aside...
That's not what I hear from urologists. Urologists in practice in Melbourne tell me they reckon there's only 3 or 4 who really know what they're looking at.
Undoubtedly, MRI of the prostate is actually a bit complex and it should be done in the hands of experienced people. But, I now think that because in Australia there has been a huge growth in this and now it's going to be reimbursed, I think we will see the quality of MRI become more consistent and concordance become more consistent. And ultimately, this will, number one, save men from having biopsies in the first place. And certainly, number two, men on surveillance are also entitled to get an MRI scan done once a year, thanks to the recent federal budget. And I think this is one of the things that will mean this data we're showing today will be offset a little bit by the fact men are going to definitely have MRI scans, at least, if not a biopsy.
Declan, thank you very much for joining us.
Pleasure.
Declan Murphy, who is a urologist and Director of Genital Urinary Oncology at the Peter MacCallum Cancer Centre in Melbourne. You've been listening to The Health Report. I'm Norman Swan. I really look forward to your company next time.